So you have four processes of respiration. First, you have pulmonary ventilation, which is just breathing in and out. You have internal and external respiration. External respiration is the gas exchange between the lungs and blood, and internal respiration is between the blood and the tissues. And then there's transport of those gases. And so these four processes are happening simultaneously during the processes of respiration. You have two zones. You have a respiratory zone, you have a conducting zone. The respiratory zone is actually the site of gas exchange. It contains the respiratory bronchioles with these little clusters of grape-looking things called alveoli, and inside those you have the alveolar ducts. And so this is where gas exchange takes place. The conducting zone is simply the tubes that lead to that respiratory zone. So in your slides, I'm going to have you memorize the functions of the nose. Also memorize the functions of the nasal concha. The nasal meatus the meatus just means groove, so those are just the grooves between the concha. The paranasal sinuses, you have the frontal, you have the sphenoid, the ethmoid, and the maxillary, and they're found within those bones. And their function is to lighten the skull, secrete mucus, and also to help warm and moisten the air. Now, rhinitis means inflammation. Rhine, we think something nasal, right? So we have rhinitis, which is inflammation of the nasal mucosa and the nasal cavity. Now, because there's connections to the sinuses, this can spread to the sinuses, and you end up with sinusitis. It can also get into the lower respiratory bronchi and cause a respiratory infection. This just gives a nice visual of the nasopharynx, oropharynx, and laryngopharynx. It's more applicable for lab material. On this slide, I mainly want to focus on the function of the soft palate and uvula. When you swallow, it closes off the nasopharynx. So the larynx is the structure that contains the vocal cords. The vocal folds are the true vocal cords. That's what produces your voice. It's also an airway because it goes into the trachea, right, the larynx. And it routes the food because you've got this little flap called the epiglottis. So when you swallow, it closes off the glottis, the opening to the larynx, and allows the food to go down into the esophagus. This just gives you a nice visualization of the larynx from the anterior view. This gives you a visualization having like a sagittal section of the larynx, and you can see the vocal cords within. Now, as I said, the vocal folds are the true vocal cords, and they are what vibrate to produce sound. The vestibular folds are the false vocal cords, and they do not play any part in sound production, but they do help close the glottis when you swallow. Now, this view is looking down the throat, and you can see the white bands are the true vocal cords, and lateral to that are the false vocal cords. And you can see how they open and close, so you get this vibration of the vocal cords that's going to generate the sound. Now, some other things, besides expelling the air through the glottis to vibrate those vocal cords to create speech, we have pitch. That is determined by length and tension on the vocal cords. You have loudness. That's how forcefully you push the air through the vocal cords. And then there's other structures to amplify and enhance the sound, like the pharynx, the oral, nasal, and sinus cavities. You can shape the sound with other accessory organs like your tongue, your soft palate, lips, things like that. Now, Valsalva maneuver is when you bear down. And so this is the intra-abdominal pressure that you put into your abdomen when you empty your rectum, but it's also when you lift a heavy object. And Valsalva maneuver is actually an orthopedic test for herniated discs. And there's another one called Desjardins triad, which is forcing a cough, forcing a sneeze, and doing a Valsalva maneuver. And those three things to assess if there's pain, which could indicate a disc problem. Of course, you can't diagnose a disc without an MRI. The trachealis muscle will contract to expel mucus during coughing, and this muscle is located between the esophagus and the trachea. This gives you a visualization of the trachealis muscle, also looking, down the throat, looking at the esophagus posteriorly and the trachea anteriorly. Now, the bronchi, each one's a bronchus, right? So we're going to come down the trachea. The last tracheal cartilage is called the carina. It's going to split, and we're going to have a primary left and a primary right bronchus, and then they're going to split into secondaries, and those secondaries split into tertiaries. Now, the secondary bronchi, we have 3 on the right because there's 3 lobes on the right lung, 2 on the left because there's 2 lobes on the left lung. But this branching is going to happen about 23 times, and it's going to continue to get smaller and smaller and diverge more as we do that. Now, once we get to less than 1 millimeter in diameter, when these bronchi continue to split, they are now called bronchioles. You can see the carina that I kind of outlined in red there. It's the last tracheal cartilage, and also the little arc that I put for the cardiac notch of the left lung. Now, each lung has about 300 million alveoli. And so those little sacs where we're going to have the gas exchange. Here's a nice visualization of the alveoli with the alveolar duct inside, hard to see, but it's inside. And then the respiratory bronchioles leading up to that alveolar sac with the alveoli. Now the alveoli have a thin wall of squamous, these flat cells. They're called type 1 alveolar cells. Type 2 alveolar cells, which we'll visualize on the next slide, they are going to produce a chemical called surfactant, and surfactant's job is to reduce surface tension. And what does that do? That prevents the collapse of the alveoli. So the type 2 cells also secrete antimicrobial proteins in addition to the surfactant. Here you can see the little green guys. Those are the type 2 cells. Those are the ones that are producing surfactant, that are lining the inside of the alveoli with that chemical, that surfactant. And again, it prevents them from collapsing. I just want to make a comment on this slide that this dude looks super happy. Okay, we know that pulmonary circulation doesn't supply the lungs, but it does take deoxygenated blood from the heart to the lungs, fills up that blood at the lungs with oxygen, and takes the blood back with pulmonary veins back to the heart. Also, I mentioned about this ACE, this angiotensin-converting enzyme in a previous chapter. That is produced by the lung capillary endothelium, and those enzymes are what converts angiotensin 1 to angiotensin 2. Now, bronchial arteries, these are the ones that supply the lung tissue. These are a branch of the systemic circulation. So bronchial arteries supply the lung tissues, bronchial veins drain the lung tissues, and the bronchial veins will actually merge with the pulmonary veins, and that's how you're getting the blood back to the heart. Now, just like the heart had pericardium, this covering, we have in the thoracic area and the lungs, we have this stuff called pleura. It's a double-layered serosa. We have parietal pleura, which covers the thoracic wall, but then we have visceral pleura, which is on the organ, which is the lungs. And it's actually one layer that's kind of doubled over. And so what it does is it creates a cavity called the pleural cavity, and it's filled with pleural fluid. The function is to lubricate the lungs, and also it creates a surface tension. And don't forget, we're going to have surfactant in the alveoli that reduce that surface tension so they don't collapse. And we'll be talking about the pressure in the pleural cavity versus the pressure inside the alveoli as well in a little bit. Here's a nice visualization of the pleura attached to the thoracic wall being continuous with the pleura attached to the lungs. Now, atmospheric pressure is the pressure outside the body, and we're going to compare things to atmospheric pressure. So when we say something is a negative pressure, that means it's less than atmospheric pressure, so a negative respiratory pressure. A positive respiratory pressure is greater than atmospheric pressure, and a zero pressure is equal to atmospheric pressure. Two other really important pressures are the intrapulmonary, also known as intraalveolar pressure. This is the pressure inside the alveoli, right, inside the lungs. And this is going to change. It's going to be a negative pressure, positive pressure, and zero pressure at different points in the respiratory cycle. Intrapleural pressure is the pressure inside the pleural cavity. This is also going to fluctuate, but it must always be a negative pressure. It has to be less than atmospheric pressure, and it has to be less than intrapulmonary pressure, and I'll explain why on the next couple slides here. Now, transpulmonary pressure is the pressure, basically the intrapulmonary pressure minus the intrapleural pressure. And as I wrote here, this number must be greater than zero, because if the pressure inside the pleural cavity, which is outside the lungs, equals or exceeds the pressure inside the alveoli, the lungs will collapse. Now, lung collapse is called atelectasis, and atelectasis can be caused by a number of things. It can be caused by plugged bronchioles. It can be caused, probably most commonly, by something called pneumothorax, which is air that gets in the pleural cavity from a puncture wound. This is treated with, you put a chest tube in and it gets the air out of that pleural cavity. As you put air into the pleural cavity, you're putting substance in there. As we put more substance in the container, the pressure in that container goes up. If that pressure goes up, it exceeds, in the pleural cavity, the pressure that's in the alveoli. What did I say happens? Well, we get that lung collapse. Okay. You could also have something called hemothorax, which is blood that gets in that pleural cavity as well, would cause the same effect of the lung collapse. So we have to establish a few principles so we can understand this breathing mechanism. The first is we know that substances, right, concentration gradient, we would like to move from high to low, right? So like if it's sodium moving, it wants to move from high to low sodium. Well, gases also flow from high to low when it comes to pressure. So we're always going to move from high to low pressure. We're going to need to keep this principle in mind when we talk about how we're going to get air to go in and how we're going to get air to go out. So for Boyle's law, we want the takeaway, right? So the equation says that the pressure times the volume at one point in the respiratory cycle is equal to pressure times the volume at any other point in the respiratory cycle. Here's what this tells us. It tells us that as volume changes, pressure changes, and they are inversely proportioned. So in other words, if I change the volume, and the volume is talking about the lungs, the volume of the container. If I change the volume of the container, so the container gets bigger, the pressure goes down. If the container gets smaller, the pressure inside goes up. And that's our takeaway from Boyle's law. All right, now here's where we're getting to the meat and potatoes of the physiology, all right? So we have two inspiratory muscles for normal inspiration. Diaphragm, which is about 75% of your inspiration, are responsible for it, and the external intercostals, which are responsible for about 25%. What the external intercostals will do when they contract is they will pull the rib cage up and out, making space and expanding the thoracic cavity. The diaphragm will contract and push inferiorly, so it will push the abdominal organs down to also expand the thoracic cavity. Now, when we expand the thoracic cavity, we are making the thoracic cavity bigger, which also makes the lungs expand. And when the lungs stretch and expand, what do? We made the container bigger. We got to go back to Boyle's law. When I make the container bigger, what happens to the pressure inside? The pressure drops. When the pressure drops below atmospheric pressure, guess what we have done? We now made the pressure inside lower than the pressure outside, and where does gas move? We said it moves from high to low. And so that's what you have happening here as we expand the container by contracting these muscles. Now, if we want to contract more forcefully, then we're going to recruit more muscle fibers of these skeletal muscles, right? So we're going to recruit more motor units, more muscle fibers, get a stronger contraction of the diaphragm, stronger contraction of the external intercostals, get a bigger inhalation. However, let's look at the next slide. If we have extreme forced inspiration, right? So when we have forced inspiration, yes, we're going to contract the diaphragm and the external intercostals more, but we can also recruit with forced inspiration additional muscle groups to help expand the thoracic cavity a little more. So the scalenes, the sternocleidomastoid, and the pectoralis minor are all additional accessory muscles that help in forced inspiration. Now, I went over this already on the actual slide, but this gives you a nice picture view and the 5 steps where we have gas flowing into the lungs, because what we did is we expanded the lungs, the pressure went down, gases went in, and then what's going to happen, if you look down at the bottom, it's going to get back to zero pressure. And why? Well, as the air goes into the lungs, what's going to happen? Well, you're filling the container with a substance now. When we put something in a container, or more of a substance in a container, what happens? The pressure goes back up. So as I expand, the pressure drops, the air goes in, and as the air goes in, it makes the pressure start to go back up until we get back to zero pressure. Now, the expiration is the exact opposite. So your normal expiration, what muscles contract? The answer is none. In normal expiration, we relax the diaphragm, we relax the external intercostals, and what happens? The thoracic cavity goes back down in size, the lungs shrink in volume as well, and when the lung volume container, the container of the lungs, goes down, the pressure inside goes up. Now, what do we say? Pressure moves from high to low, so when the pressure inside exceeds the pressure outside, the air flows out of the lungs. Now, it's going to go back down to zero just like it did with inspiration, because as the substance is leaving the lungs, the pressure begins to drop again. And then we get back down to zero pressure. Now, also on this slide, very important, for forced expiration, we will activate some muscles. The abdominal muscles, specifically the oblique muscles and the transverse muscles in the abdomen, as well as the internal intercostals, they will contract to make the volume of the thoracic cage smaller, again, making the lungs smaller, making the pressure even higher so we can get more air out. And then you can review this slide as well in your slides. It gives you the steps again and a visual for the expiration process. Now, before I get into the factors influencing pulmonary ventilation, which I'm going to do on the coming slides, I want to talk about atmospheric pressure. As I go up in altitude, atmospheric pressure drops. And as I go down in altitude, atmospheric pressure goes up. So there's an inverse proportion. So when you're climbing a mountain, the atmospheric pressure is actually dropping. And so the higher you are, the lower the atmospheric pressure. Why is it more difficult to breathe? Well, yes, there may be less oxygen available at those altitudes, but also the atmospheric pressure is significantly lower than at sea level, right? So what's going to happen, depending on how high you are, the higher you are, the lower the atmospheric pressure. How do we get air in the lungs? We have to get the pressure inside the lungs lower than the atmospheric pressure, which means we have to expand even more. And so that gives you an idea of why we have to, it's so much more difficult to breathe at those higher altitudes. All right, so the first factor hindering ventilation is airway resistance, right? So if you have constriction or obstruction of the bronchioles, that would hinder the air, right? So it would increase the resistance in those tubes, and it would hinder or obstruct air from getting in and out. And so asthma is a good example of this because you get this broncho constriction, so the little bronchioles will constrict. Also, you get some fluid accumulation there, blocking the passageway. And so that's a good example of an airway resistance problem. And an epinephrine is something that can be used to dilate bronchioles, also reduce air resistance. However, it's not usually used in asthma, although there are some medications that contain epinephrine bases. But some of them are just like Pleurae, things like that. That's something that will just target dilating the bronchioles. We've kind of talked about this one already because we talked about surface tension is that tension that can cause lung collapse. So surfactant is that chemical produced by those type 2 alveolar cells that reduce the surface tension, preventing the lung collapse. Now infants that cannot produce this yet, they have something called infant respiratory distress syndrome. And basically the alveoli will collapse because they don't have the surfactant to maintain and keep the alveoli open. All right, the last is lung compliance. This is the distensibility or ability to expand the lungs. And there are things that can affect that like scarring, fibrosis, even a reduced production of surfactant can do that. Decreased flexibility in the thoracic cage from calcifications and things like that. Let's look at the next slide. We have a few more. So calcification of costal cartilage, which is the cartilage, the rib cartilage. Deformities of the thorax, something like scoliosis. Or something like paralysis of intercostal nerves, because we know that intercostal muscles are respiratory muscles. So if we paralyze the nerves that control them, that would also inhibit the expansion of the lungs. All right, on this slide I told you to memorize tidal volume, which is your normal inspiration equal to your normal expiration. What is inspiratory reserve volume? Breathing above tidal volume. Expiratory reserve volume, breathing out or expiring out above what you can breathe out for your normal tidal volume, and then the residual volume, which is the amount left in the lungs. But go ahead and read all of those. Also memorize vital capacity, which is on the bottom here, and that should do it. Don't worry about the numbers. So alveolar dead space is essentially alveoli that are no longer functional, but we do have an anatomical dead space because you have a bunch of tubes. Remember the conducting zone? Well, there's no gas exchange in the conducting zone. That's just a way to get the air to the respiratory zone. Now, if you add those up, you end up with your total dead space. Now, in a normal breath, we get about 70% of the air in the tidal volume, the normal breath, to the respiratory zone. About 30% remains in the conducting zone. Now, changing your breathing can actually change this number. Let's look at the next slide. So slow, deep breathing is going to increase your alveolar ventilation rate. Rapid, shallow breathing is going to decrease your alveolar ventilation rate. What does this mean? This means the amount of air or gas getting to the alveoli per minute. So we're going to memorize our numbers. We get about 70% of the air, right? 70% ventilation to the alveoli in a normal breath. If we have that slow, deep breathing, it can go up to about 85%. And if we have rapid, shallow breathing, it can drop to around 40%. And go ahead and memorize those numbers. Now, a spirometer is an instrument that measures respiratory volumes and capacities, and so they can be used to distinguish between obstructive pulmonary diseases and restrictive disorders. Now, obstructive diseases, I don't want you to get confused on this because we said that there's airway resistance. When we have things like asthma, I said before, bronchitis is very similar to some of the symptoms you'll see with asthma. Those are obstructing the actual airway because the bronchioles are constricting, there's mucus formation and exudate forming inside those bronchioles. It's blocking, right? A restrictive disorder is something that restricts the expansion of the lungs, so things like tuberculosis or fibrosis. All right, Boyle's law, the big takeaway is that your partial pressure is directly proportional to the percentage of that gas in a mixture. So if I say the partial pressure, the PO2 goes up, so the partial pressure of O2 goes up, I'm saying the concentration of O2 in that solution went up. If PO2 goes down, the concentration of O2 in that solution went down. So that's the takeaway. Henry's law, we want to know that gases dissolve in proportion to their partial pressure, so just understanding that principle, but also memorizing that carbon dioxide is about 20 times more soluble in water than oxygen, and nitrogen is practically insoluble. Ventilation-Perfusion Coupling. What is this saying? Well, perfusion is the blood flow that gets to the alveoli. You can go back in your notes and look at the picture of the blood vessels, the capillaries surrounding the alveoli. So we need good blood flow to those. Ventilation is the amount of air that gets to the alveoli. So we need both. We need good blood supply and good air getting to the alveoli so that we can have good, effective, efficient gas exchange. You've memorized before, but memorize again that each red blood cell has about 250 to 280 million hemoglobin, and every one hemoglobin can carry up to 4 oxygen. A couple of other principles. As the oxygen begins to bind to hemoglobin, hemoglobin gets a greater affinity to bind more oxygen. Remember, affinity means the ability to bind to, so it gets better. The more you bind oxygen, the more easily you can bind it. The opposite is also true. As you release oxygen from the hemoglobin, the ability to bind the affinity for oxygen to hemoglobin decreases, so you can unbind it. It becomes more efficient. If you have all 4 heme groups on the hemoglobin, oxygen attached to all 4, it's called fully saturated. If you do not have all 4, you have less than all 4, it's called partially saturated. Now, when you go around in a circulation, you're not going to deliver all the oxygen. We're not dumping off all the oxygen like a dump truck from the hemoglobin and from the red blood cells. We deliver about 20 to 25% of the bound oxygen during one systemic circulation. However, if the demand goes up, we are able to deliver more and make that percentage go up to release more oxygen per systemic circulation. Now, this slide has to do with the unloading of oxygen. So these are things that would increase the unloading of oxygen. I'm going to do it a little bit out of order, but we'll talk through each of these 4 points. 1, if I have a decreased concentration of oxygen, that means, see that PO2? We said that if we have a decreased partial pressure of O2, that means a decreased concentration of oxygen. So what does that mean? That means we're going to unload more oxygen, right? So number 1 would increase unloading of oxygen. Now let's go to number 4. Number 4 says increased PCO2. So that means the partial pressure of CO2 goes up, which, as we said before in some of my live lectures, and we've talked about this, that if carbon dioxide goes one way, oxygen usually goes the other. So this is perceived as the same as a decreased PO2. And what do we say happens then? We unload more oxygen. We also said, number 3 we'll go to, we said that CO2 and hydrogen ions like to play together. So if carbon dioxide goes up, then hydrogen ions go up. So if hydrogen ions go up, that means we have a decreased pH. And a decreased pH means what? More acidity. And in this case, we're going to unload more oxygen as well. Because again, remember, if H is high, that's the same as PCO2 being high, which is the same as PO2 being low. All right, the last one is just memorize increased temperature. As we increase temperature, we will increase loading of oxygen as well. Now, you can read these, but I'll go through them kind of fast. Hypoxia is inadequate oxygen getting to the tissues. It can lead to this blueness called cyanosis. The different types of hypoxia that you can encounter are anemic hypoxia. We talked about different anemias that would produce either too few red blood cells or some type of abnormal or deficiency in hemoglobin. Ischemic hypoxia. Ischemia means a decreased blood flow, so anything that impairs circulation. Histotoxic hypoxia, histo means tissue, toxic means toxic, so we're talking about metabolic poisons that cause the cells to not be able to use the O2. Hypoxemic hypoxia is some type of pulmonary disease causing an abnormal ventilation. And then carbon monoxide poisoning also can do this because carbon monoxide binds to hemoglobin with about 200 times the affinity as oxygen. Now, oxygen, we said, can bind reversibly, just like carbon dioxide. It binds to hemoglobin, unbinds from it very easily. Carbon monoxide binds to the hemoglobin and does not want to let go. So what it does is it blocks the binding sites for oxygen, and this can be very dangerous. Now, nitric oxide is a vasodilator, and hemoglobin is actually a nitric oxide scavenger, so it would destroy the heme would actually destroy nitric oxide. So what nitric oxide winds up doing, because it's essential, it's as the hemoglobin binds oxygen and or carbon dioxide, depending on where we're at. As it binds it, the nitric oxide is going to attach to the cysteine amino acid on the hemoglobin, which is going to prevent it from getting scavenged. And then when we deliver the oxygen and or carbon dioxide from the hemoglobin, the nitric oxide detaches and then does what nitric oxide does, right? It's a vasodilator, so it causes vasodilation. So this talks about the nitric oxide causing vasodilation, but also you kind of have my little analogy here. I use the Millennium Falcon and the Star Destroyer, and so in the Star Wars movie, I believe it was Empire Strikes Back, the Millennium Falcon hid on a tower of the Star Destroyer, and it's just like the nitric oxide hiding on the cysteine amino acid so that it didn't get scavenged or destroyed by the hemoglobin. So we have one of three chemical buffer systems that we go over in this chapter because carbon dioxide is intimately involved in the structures of carbonic acid and bicarbonate. So in fact, on a previous slide that I did not include in this video, it says that 70% of the carbon dioxide in your body is carried in the form of bicarbonate. And so we have this buffer system. And so what happens is every one bicarbonate you have will bind one hydrogen. Every one carbonic acid will release one hydrogen. So if you have to buffer, right, if you have to take hydrogens out of a solution to lower the acidity or put hydrogens into a solution to raise the acidity, we can use one of these two chemicals to do the appropriate response. Now we do have a respiratory buffer system, and the respiratory buffer system is essentially this. We can get rid of carbon dioxide or we can preserve carbon dioxide. So when I slow, shallow breathe, what's going to happen is I'm going to increase carbon dioxide levels, and that's going to drop the pH, because remember what I said, as carbon dioxide goes up, hydrogen goes up. What does that mean? That means the pH goes down. If we rapid deep breathe, we flush out carbon dioxide so it decreases, which means we're going to decrease hydrogen ions, which means we're going to cause a rise in pH. An easy way to remember this is when you're breathing for exercise, right, these deep, rapid breaths, you're not trying to get oxygen in, you're trying to flush carbon dioxide out. So that's an easy way to remember which one does which. Now, neurological control of respiration, we have two groups in the medulla. One is called the ventral respiratory group. This is going to control your normal breathing rate, called eupnea. EU means good, PNE means breath. This is your normal breathing rate, which is approximately 12 to 18 breaths per minute in adults. Now, as far as function, we have inspiratory neurons. They are going to stimulate through the phrenic nerve, they're going to stimulate the diaphragm, and through the intercostal nerves, they're going to stimulate the external intercostals. And we said those muscles are muscles of inspiration that expand the thoracic cavity. So air is going to go in. How do we shut them off? Well, expiratory neurons are actually going to block the inspiratory neurons. And when that signal stops to the diaphragm and external intercostals, they relax, the container gets smaller, and the air goes out. The dorsal respiratory group, also found in the medulla, is responsible for giving information to the ventral respiratory group. So it's going to pick up information from stretch receptors, from chemoreceptors, and then it's going to send that information to the ventral respiratory group so that it determines, changing the rate and depth of breathing. The last group is the Pontine group. This is found in the pons, this respiratory group, and it's going to modify some activities of the ventral respiratory group. Things like fine-tuning for breathing when you're talking, like I'm doing now, or sleep, or exercise. And so it's going to help modify those. It also smooths out transitions between your inspiration and your expiration. How do we change depth and rate of breathing? Well, the depth of breathing is determined by how actively the respiratory center stimulates the respiratory muscles, right? So our depth, right, if we fire a stronger stimulus and we get a stronger contraction of the diaphragm and external intercostals, we get a deeper breath, right? The rate is determined by how long the inspiratory center is active. So if we're turning it on and off, on, off, on, off, on, off, right, that's shorter. If we turn it on and there's a little delay and then we turn it off, right, that's going to determine the rate or the respiratory rate. Hypercapnia is an increased carbon dioxide level in the blood. Okay, it's going to result in an increased rate and depth of breathing to flush the carbon dioxide out. Now, however, what if we are at normal and we increase the rate and depth of breathing? So in other words, there's not a high carbon dioxide level. What's going to happen? Well, we're going to continue to flush carbon dioxide out, so this hyperventilation is going to wind up causing hypocapnia, right? A decreased carbon dioxide level winds up causing decreased blood flow because cerebral blood to the brain, because cerebral blood vessels will constrict, causes dizziness and fainting. The other term I want you to know here is the apnea. A means without, PNE means breath. So there's a cessation of breathing. Now, we have many causes of acidosis, but we have one cause of respiratory acidosis. Now, regardless of what the cause of acidosis, the respiratory system will try to help balance the acidosis or alkalosis. So remember, 7.35 to 7.45 is your normal physiological pH. Below 7.35 is acidosis. Well, carbon dioxide retention could cause acidosis. That's specifically called respiratory acidosis. Anything else that causes acidosis, like a lactic acid accumulation, like the ketone bodies caused by excessive fatty acid breakdown in diabetic patients, those and a number of other things can cause metabolic acidosis. Okay, but again, the respiratory system is going to try and balance any of them. Now, some other influence on breathing, we have hypothalamic control. In the hypothalamus, you have the limbic system, and this is going to help modify rate and depth of breathing based on emotion, right? Limbic system is the emotional system, and so anger, sometimes breath gets like fast and short, and sometimes people hold their breath, or we can see this a lot in infants when they get angry and hold their breath. If we go down to number 3, cortical controls. I can change breathing based on the cerebral cortex. I can change it based on conscious control. However, let's say I hold my breath. There's going to be a point in time when the medulla takes over and it shuts down, it shuts off, or it overtakes the cortical system and causes you to take a deep breath, or causes you to take a breath. Okay, and the number 2 there, the rise in body temperature will increase your respiratory rate. So those are things that affect respiratory rate. The Herring-Brewer reflex, this is a protective reflex. It's very similar to the atrial or Bainbridge reflex we saw in the heart. That was to protect overfilling of the atria. This one is to prevent overfilling or overinflation of the lungs. This is a protective response. This doesn't happen, this inflation reflex doesn't happen every time we breathe in. Okay, it's just an overinflation. Then, we get this signal that stimulates the centers to stop the inhalation, right, inhibitory signal, and so it's a protective mechanism. Hyperpnea during exercise. This can increase ventilation 10 to 20-fold. Go ahead and memorize that. If you go to high altitudes very quickly, there is something that could happen called acute mountain sickness. Headaches, shortness of breath, nausea, dizziness are some common symptoms, but in severe cases it can cause cerebral edema or pulmonary edema, and it can be lethal. This happens commonly when you at ski resorts, because you're going up to high heights very quickly on the ski lifts. Also, like a helicopter, it doesn't pressurize, or maybe some of them do, but helicopters don't usually pressurize, so you're going to high altitudes very quickly. Acclimatization, we've talked about some of this in other chapters. This is you're acclimating to being at higher altitudes. So the 2 things we talked about before is the increased production in EPO, which is erythropoietin, which is going to cause you to make more red blood cells. That's number 3. Number 4 was angiogenesis, which I added down there. That's the increased production of blood vessels, or even enlargement of blood vessels. The 2 that have more to do with the lungs are going to be the increased sensitivity to carbon dioxide and oxygen levels by these chemoreceptors, so they become more responsive. And then we're going to also increase ventilation. Remember, if you're breathing, those breathing muscles are skeletal muscles, and if you're using them more, they're going to get stronger, and it's going to increase the actual amount of liters per minute that you can have during with your ventilation. Adjustments to high altitude takes at least 3 to 4 weeks, according to research. So to get benefits for training, for increased performance, it's not going to happen, within a week or 2. All right, we're almost done here. We've got chronic obstructive pulmonary disease, which is exemplified by 2 key things: chronic bronchitis and emphysema. Now, what's going to happen is, we'll talk about these 2 in just a minute here on a different slide, but, and I won't worry too much about some of the treatments. There's a number of drugs that are used in oxygen and sometimes surgery to treat this. But this is irreversible COPD, okay? And so some features that you're going to see that are really important to memorize are that history of smoking in 80% of patients, which is a very high statistic. There's going to be difficulty breathing. Dyspnea, PNE means breath. DYS means difficulty, or so this labored breathing. Coughing and frequent pulmonary infections found in people that have COPD, and eventually develops respiratory failure with respiratory acidosis. Now, chronic bronchitis, itis is inflammation. Chronic, this is long-term. So not only is there inflammation, you're going to have a fibrosis of these passageways, which is kind of a scarring, and these are going to obstruct the airways, as well as a chronic excessive production of mucus to obstruct the airways. Emphysema is an actual destruction of the alveoli, where you lose the elasticity of the alveoli and they can no longer exhibit gas exchange. This slide also gives you a nice view of chronic bronchitis and emphysema and a few key things about them. Go ahead and read this slide. Okay, so asthma, we've got inflammation, we've got bronchospasms, which is the constriction of the bronchioles. This is an immune response. And you're also going to produce this fluid called exudate that's going to block the tubes as well. So not only the spasms, but the fluid. About 1 in 12 people in North America suffer from asthma. And so this is some of the key characteristics you want to memorize. Now, there is no permanent damage with asthma or asthma attacks. So that's how it's different than things we see, like some of the characteristics of COPD. Okay, tuberculosis is caused by a bacteria called Mycobacterium tuberculosis. Some key characteristics of symptoms are racking cough and coughing up blood. Also, the treatment is a 12-month course of antibiotics. Some important statistics on this slide. The leading cause of cancer deaths in North America is lung cancer. Lung cancer is the number one leading cause of cancer among men only, among women only, and then if you put men and women together, it is still the leading cause of cancer deaths in men and women together as a cohort. So it's in all three categories, it's the leading cause of cancer death. 90% of all cases of lung cancer result specifically from smoking. And lung cancer metastasizes very rapidly. Most victims do die within a year. The three most common types that I'd like you to memorize for lung cancers are adenocarcinoma, squamous cell carcinoma, and small cell carcinoma. Cystic fibrosis is the most common lethal genetic disease, and what it does is it blocks air, it blocks ducts. So you have these passageways in the lungs, the bronchi or bronchioles get blocked by this mucus production clogging the passageways. It can also happen in pancreatic ducts, blocking digestive juices, and even reproductive ducts, blocking the uterine tubes. All right, here we are at the finish. By the 28th week, the premature baby can breathe on its own. This is when it's able to produce, around this time, surfactant, so it can keep the alveoli open. It does take about 2 weeks after birth for the lungs to fully inflate. Now, the respiratory rate for an infant or a newborn is going to be about 40 to 80 respirations per minute. We know for adults it is 12 to 18.